Well, I have to say, I am just so pleased to be here among like-minded individuals who care about this topic. And I will alert you to the fact that I also have changed my title from the one that's in your agenda. And it's a two-part title. The first part, Using All the Data, is meant to be a nod to the fact that 80%, at least, of all data have a spatial component, and that geomedicine is about leveraging that important geospatial information to improve health. The second part, however, is where I'm going to focus my comments today, and it is about combining clinical and public health sources to improve health. And so what I hope to do is to combine my experience at the California Department of Public Health, where I was a deputy director in the Center for Health Statistics and Informatics, with my experience at UC Davis as an internist and faculty clinician, and show you how, as Bill showed with the railroad tracks, these two worlds are converging. And we're seeing a blurring of the lines between public health and personal health to our benefit. And I think it creates new opportunities, one of which is geomedicine. So the way that I'm going to approach this is to talk about the enabling technologies. I'll spend quite a bit of time there. And then just to help spur your imagination from the cases that you may know, I'm going to share with you some use cases that I know about that use geomedicine in really interesting and useful ways, hopefully beginning to show that return on investment that we've heard about. And then at the end, just a few, not random, but additional thoughts that go along with how we need to think about this technology. So as I start, I wanted to begin with this quotation that I came across just last week that I really liked from T.S. Eliot, who said, "The purpose of literature is to turn blood into ink." And of course, he's talking about blood as life, or the life force, and how literature really captures life in words. And I think actually that we do something similar in health information technology. You didn't know that we were so poetic. But we actually take life source, and turn it into scads and scads and scads of data, and that is our ink. So I would just have you think about it in this way. My little quotation now is that the purpose of geomedicine, then, is to turn ink back into blood. We want to take and use all of that great data and turn it back over to improve personal health. So the enabling technologies, as you can imagine, things are converging nowadays so that we have electronic health records, health information exchanges, open data, and big data. So my plug, I already warned Cerner that I was going to do this. First of all, the electronic health record must be able to accommodate and geocode standardized addresses. And I would go a step further to say that ideally, the medical record will start to have living and workplace histories with beginning and ending dates for each when we start to look at a long-term continuity of care over the lifespan. So let's talk about electronic health records. As we all know, I just want to give you a context for all of this. There is increasing adoption in the United States. Here you see two lines. The blue line is representing over time the adoption rate of any EHR system. I kind of ignore this one because it includes billing systems, so not really the things that we're thinking about as much. But the more important line is the green line, and it's showing that, that there is a constant increase in adoption rates, and that as of 2013, across the United States, that rate is at 48% on average. If you want to see that by state, you can see that some states in darker green are doing a little bit better, have a higher rate of adoption, and then a number of states in white are lagging a little bit behind and in their adoption rate. Nevertheless, it is happening, and part of that is through this history of policies, starting with the American Recovery and Reinvestment Act in 2009, where the idea was to reinvest in the economy in certain areas. And one of those areas was health information technology. And from that was born HITECH, the Health Information Technology for Economic and Clinical Health Act, And this all leads toward healthcare reform, which, as you all know, we're trying to move from this volume-based system to a value-based system, which is intended to give us a lot of good return on investment, such as complete and accurate information for our patients, improved clinical outcomes, better access to information. You know, I remember as a medical student reading notes that were handwritten, and nothing against surgeons, but especially one surgeon's note comes to mind where I was reading and it said, "The most critical thing we must do is," and I couldn't read the next word. It was so frustrating. I must have spent like an hour reading that word and every possibility with the handwriting. But definitely we have better access to information even just because we can read it. More robust research data. Now I do know and recognize that most electronic health records are for clinical purposes and not for research purposes, but hopefully as they evolve, they'll give us better access to information that we can actually use for research. Certainly patient empowerment and improved population health outcomes are additional hopes that will come from this progression of era to high-tech to healthcare reform. But I want to go back to high-tech and contextualize that a little further, because I think what's really important about it, at least with regard to the convergence of public health and personal health, is meaningful use. And so meaningful use is where we're getting the incentive payments to adopt electronic health records. And it has 3 stages, and I've categorized them quite broadly for my own purposes, but I think of stage 1 as data capture. We're actually able to get data in the electronic health record that is useful. Stage 2 is about sharing data with public health. It's about many other things, but that in particular is of interest. And stage 3 is about bidirectional sharing of data and outcomes. So the idea is that providing incentives for all this and providers actually meaningfully use an electronic health record then will increase adoption and thus opportunities to use that data. So the public health objectives of meaningful use stage 2, which is where we're at right now, public health is now going to be getting clinical data. Now they were in sort of fax and other forms like electronic lab results, but now they're going to get it in a more timely manner, hopefully more comprehensive data, and in the future just think of public health may have less reliance on survey data. If we have a huge level of adoption in the United States for electronic health records and everybody is sending their data as they should to public health, then you have population data that's accurate, potentially. So something to think about. And the objectives for stage 2 include having electronic data for immunizations, so being able to have statewide immunization registries, reporting laboratory results, particularly for infectious disease laboratories, conducting syndromic surveillance. That one's a little fuzzy, but certainly has a geospatial component, as you can imagine. Cancer cases, reporting that for a cancer registry. Again, a geospatial issue with cancer clusters and access to care, treatment options for patients. And then other registries, which I love, it's included, but it's very poorly defined, and we can just make that up if we find something really important. So, but soon I would say that public health is going to be able to then turn that data, reflect it back to clinicians. So again, it's that sharing that adds value. So I want to show you that that is done through the health information exchange idea. So clinicians pool their data, send it through a health information exchange, which then parses it out to the programs in public health that need it. Public health then can use the health information exchange to reflect that data back to local public health departments, or presumably back to clinicians and health systems that need the data. So I want to give you an example of this using immunization information. So immunization registries, I think you can imagine at a statewide level could be extremely useful, and you know, what the heck, let's think nationally. A national immunization registry would be fantastic, where you can consolidate one child's immunization history into a single record. So that would provide an accurate official copy of the child's immunizations for all of those things that kids do. They want to go to camp, or they need to go to school, or other reasons that they have to have those immunizations handy. It can help to ensure that a child's immunizations are up to date, and if in fact they're not, then reminders can be sent out to ensure that immunizations that are due actually happen. So this seems so obvious, and yet I can tell you in my state, in California, we don't have, until recently, a statewide immunization registry. This was not useful to me growing up. So I have a wonderful mother, and she made sure that I got all of my childhood immunizations. But at the time, they were all on this little paper card that she was supposed to file in a safe place. And safe places, you know, sometimes aren't easy to remember. So no record could be found when I was going to do my undergraduate education, and so I was re-immunized for all of them. And so you would think, lesson learned, but this was still the time of paper. And then I wanted to go to medical school, and no record could be found. We even checked with the physician. He did not have a record of my immunization, so I had them all a third time. And it was a pain in the arm and in the rear end, but I can tell you I'm very well protected. So an immunization registry is not just great for patients and parents, but it's great for providers, plans, and purchasers as well. I think you can imagine that having that reliable information for any child is going to reduce paperwork and allow really good reporting on things like HEDIS measures. Facilities are going to be able to introduce new vaccines or changes in the vaccine schedule more seamlessly, and we can better manage vaccine inventories when we know where the need is. But most importantly, I want to think about this from a community and public health standpoint. When you have a statewide registry, you're able to identify high-risk populations and under-immunized populations and then target interventions. And those interventions should be done in partnership with health systems and clinicians. So again, it's reflecting the data back to where it's most useful. We can control these vaccine-preventable diseases. I'll give you some stats on why that's important, and provide information on community and state coverage rates, something that we all want to know. Again, streamlining vaccine management is very important. And you can also look at providers and their habits and ensure that they're up to date on the current guidelines for vaccinations and monitor adverse events with this kind of a system. So hopefully you're convinced that statewide immunization registry is important. However, I'm going to give you data from 2012 to show you all of the children, in this case under the age of 6, who are actually included in an immunization information system, or IIS. And I can't help but always look at California. It also stands out because it's a light blue color. In this case, that's bad, with very low participation in an immunization information system. Similar idea for adolescents. Again, California is looking pretty bad to me. And adults, overall, there's less uptake with adults in an immunization information system, but California still needs some work. Although I can tell you that we do have a public health information exchange. It's called the Gateway, and we are putting together a statewide immunization registry, so I hope that in a few years California will be a dark blue state. But why do we care? Well, because for every US birth cohort that's immunized, it saves 33,000 lives, prevents 14 million cases of disease, reduces direct health care costs by $9.9 billion, that is with a B, and it reduces the indirect costs by $33.4 billion. That's just that one intervention, vaccinating our population. So this is an important opportunity with the convergence, again, of clinical health and public health to make a difference. And we can make that difference geographically with targeted interventions. So, like I said, a lot of data is coming into public health, but public health already collects a lot of data. So the next technology that I wanted to mention is open data, to try and again, make that data available to those who need it. So open data is not about private, protected health information. Open data is about data that can actually be freely used, reused, and redistributed. by anyone, and it's subject only to the idea that people continue to share and share alike. It's typically about government data and transparency in government. And again, it's usually aggregated data or non-private data, so we don't have to worry so much about HIPAA right here. A lot of strategies go into which data sets can be opened. So I wanted to just tell you the story of open data that I think is so compelling. Maybe you've heard it. This is my open data hero, Dr. Nirav Shah, who is the former health commissioner of the state of New York, and now he's a Californian. He's actually a senior vice president at the Kaiser Foundation. And so since I've moved to Southern California, we're neighbors. Anyway, Dr. Shah, I met him in July of 2013. And he was telling his open data story. And I was so blown away, I said, we're going to do that for California. And we did. But what he told in his story was that they started small. New York started with 6 data sets that they opened to the public. And he says one of those data sets was, in his view, the most boring data set ever. He couldn't imagine anybody would care. And that was New York's nursing homes, the weekly bed census. So that's what it looked like on a map, and he put that up, and within a few weeks, we had Hurricane Irene in New York. And this data allows you, I'll blow that up so you can see, to look at any particular nursing home, see its address and contact information, but you can see what their bed capacity is, what if they have laboratory radiology facilities, if they have ventilator beds available. And so they were able, in that hurricane event, to move patients out of harm's way to a safe nursing home without having to call the Department of Public Health. They went online, they found this information, and it was so important that it made headline news the next day. Well, this impressed the governor of New York, who said, okay, well, we're going to open all our data. And so Executive Order 95 was born, and New York started doing open data and really setting, I think, the pace for the country in this area. But they're not the only ones. Gartner, who follows technology trends, has indicated that open data is one of the top 10 strategic technology trends for smart government in 2014. And the data that I'm showing here is data that I personally collected, so accuracy could be suspect. But this was casually looking at data.gov and healthdata.gov to see how many data sets are up there. And so this graphic is skewed, and I'll explain that in a moment. But I just want to show that for data.gov, we're seeing a huge number of data sets available, almost 160,000 data sets that you can download and work with and do something with. Now the health data, because it's such a smaller component, doesn't show up as actually increasing, but I can tell you in 2012 there were 411 data sets available, and we're up to over 1,600 now. So it's small, we have a long way to go, but 1,600 public health data sets is not nothing. And imagine all the data sets you've used in your life. It's probably not 1,600 of them. So this is a huge opportunity to do more with data. But all of that data from the health information exchanges and the electronic health records and open data portals creates this problem that we're all familiar with as big data. So what do we do with all this stuff? Well, as you know, big data revolves around the 3 V's. I've heard people say there's up to 7 or 9 V's, but I'm going to stick with the 3 of volume, velocity, and variety. Now, if you haven't heard the stats or something similar, just to point out the volume of data that we have, every 2 days, we collect the equivalent amount of data as from the beginning of time to 2003, every 2 days. So it's an incredible amount of data. And so that provides challenges in storage and processing, of course, and making sense of it. The velocity of data is amazing. I mean, obviously, in 2 days, we're collecting quite a lot of it. And data is coming at us fast. And it's not just the collection that is so quick. It's the processing and the demand for processing on an immediate basis. I've always said instant gratification isn't nearly fast enough, and that's true with data. People want results right away. So think about the example of credit card fraud. These credit card companies want to be able to spot potential fraud immediately so that they don't lose money, 2 weeks down the road when they finally see a problem. And then there's the variety of data. We're not just looking at spreadsheets anymore. We've got audio files, video files, click streams, data logs, many, many different types of data that need to be put together in some way, again, so we can make sense of it. So in medicine, we have genomic data, proteomics, digital imaging data, and electronic health record data. But that's not all. The data expands from there to heart rate monitors, personal sensors. We have glucose monitors, blood pressure monitors, and even sensors that look at the environment and pollutants and other kinds of environmental hazards. So all kinds of data in health are coming at us. And if you just expand your thinking a little bit, what if your physician could use retail data and find out about the bacon and Pillsbury Crescent rolls that you bought at the store? What might they say about that? Well, if this kind of example is making you a little uncomfortable, you shouldn't be surprised. It was back in March of 2011 that Time magazine had this cover talking about your data for sale. Everything about you is being tracked. Get over it. I don't feel quite as strongly about that. I do think that privacy is important and respecting the data that is available. But I think it's clear that massive amounts of data about us are out there and can be used responsibly to improve our health. And I think that's what geomedicine is about. So then you got to do something with the data. Again, something responsible, but processing big data is not a little thing. It requires hundreds, maybe even thousands of servers. And to think of any one institution having that kind of infrastructure or capacity, it's beyond most of us and being able to maintain that. And so cloud computing is a great way to take advantage of dynamically allocated computing resources over the internet. And so tools like Hadoop help us to do that and to repackage data into more consumable portions. And when I think about why this matters, why we care, I really love this graphic that was developed by Dr. Dan Mazies at the University of Washington. And he was explaining sort of in medical language and public health language what big data means and again, why we care. On the y-axis, you can see the facts per decision, and then here he's saying, what kinds of data sets support that many, many levels of facts per decision. Proteomics, genetics, structural genetics all have lots and lots of data, and it takes a lot of that to create a really unified response. And we have, of course, time across the bottom. But what I think is so interesting about this is that our human cognitive capacity has not changed. We can process 4 or 5 facts at a time. Okay? So what are we going to do with thousands of facts? We need different techniques. Things are going to change, and they are changing. But it's pretty exciting to think about. So big data. Many opportunities here. Healthcare transformation, I think by its nature and by policy you've already seen, is data and information intensive. There is an emergence, and you may have seen it in your organizations, of data scientists who can handle this kind of big data. And that is a specialization. I'll just go on a little tangent here that I've really been working on in state government, because we don't have classifications. We don't even have classifications for informatics in California, much less data scientists. So again, there's a lot to be done to make sure that we're able to have capacity to do this stuff. And of course, opportunity is to start linking these outcomes with data and compelling stories, right? We all prefer to hear it as a story with consumers and policymakers so that they get it, because we don't all get it the first time we hear it. But there are challenges, and you may have in your organization a legacy system that is integral, that can't be changed unless a huge investment of money and effort is put into it. And there is this culture of no when you get to the legal portions, thinking about open data. The lawyers are trained, well, if we say no, you're safe. And they're right. It's sort of like teen pregnancy, right? Just say no. But I don't know that that's really practical in this day and age. We need to find ways to say yes responsibly. So it's a whole new paradigm there, but it is a challenge because we're not used to doing that. And then there's going to be competition for qualified analysts because we're just beginning to see the training pipeline to get people to the capacity and ability to do big data analysis. So it's going to take a little time there. So now that you have a sense that this technology is converging to make geomedicine possible, I wanted to do the fun part, which is talk about the use cases. You know, how can we make this useful and improve health? So I have a number of cases from low-tech to high-tech, big health systems to individual clinics, so you can see where I'm going. So I like to start with what I think is my favorite example, and this is one of my colleagues from UC Davis, Dr. Eric Fernandez y Garcia, and he's a pediatrician. And in 2009, right after I saw Bill's TED Med Talk on geomedicine, I was talking to Eric about this idea. And he said, oh, geomedicine. He said, well, I never heard it called that, but I use it every day. And I said, you what? This is a brand new idea. And he said, no, I've been doing this forever. And this is what he showed me. He uses this map from First 5, and this map shows areas of Sacramento County that have fluoridated water. So the blue and the bright orange areas are fluoridated, whereas the beige and white areas are either partially or non-fluoridated water. So in his pediatrics clinic, when he sees a patient, he finds their address on the map, and if they need a prescription for fluoride, he writes it, and if not, of course he doesn't. So low tech, but truly effective. He uses it every day. And you know, from the patient perspective, they're interested in their health, I think maybe even more than ever. I'm not sure if that's the case, but they certainly are using a lot of applications that are health related. And so I just wanted to show you one that does have a very nice geomedicine component, I think, and that is iTriage. And in iTriage, you've got a lot of different things that you can do. Let me find my pointer here. You know, you can look at different symptoms and conditions and medications and procedures to learn about those things. But what you can also do is find a healthcare facility. So when I choose the facility category, I've got all different types of facilities that I can look at. So in this case, I chose the community health centers, and then I get a list of community health centers that are near me. At the time, I was living in Rancho Cordova. And then, you know, I happened to know about the effort, and I thought, okay, this is a great community center. I know that I would get good care at a reasonable price there. So I select the effort, and sure enough, it comes up on a map with contact information, and I can get directions to get where I need. So improving access to care. But you'll notice that iTriage has also got this little beta component, and that's what I think is interesting, and it's just starting to be developed. So in that beta component, they're taking information like Google would of all of the searches within iTriage for different conditions and information. So last night I just pointed to Durham to see what people around here are searching about. And they're interested in urinary tract infections, gastroenteritis, and muscle strain. So those are the top searches in this area. So again, crowdsourcing information to see what might be going on in a community when widely used could be of high value. So, you know, people like to measure things about themselves, and shouldn't that information be available to improve our health and allow us to work with our clinicians in new ways? Well, that's what's being done at UC San Diego, and one of my colleagues, Jim Killeen, is an emergency room physician, and he's embarked on this project that I think is pretty cool. So it starts with what is not an EHR solution, but I think this kind of thing could be integrated into an EHR. So he's using something called Health Vault. And we start with a patient. In this case, it is Gloria Gilliam, who is a 24-year-old young woman. And she has the conditions of eczema, asthma, and acute asthma. And she takes a number of inhalers for her condition. And so she is participating in this program. And so what she was given was a cell phone and then this little device. You may have seen it before. The company that makes it is called Propeller Health. They used to be called Asmopolis. But this sensor sits on top of the actuator, and every time somebody takes a puff, there is a date, time, and location stamp that goes through that sensor. And this little part here on the other side connects directly to the smartphone, and you can upload the information there and find out where you're using your inhaler more often. So it might look something like this. In this case, she gets a report that says that her asthma is under good control, but there are some hot spots where she's using her inhaler more often. Now, maybe they're at home and at work where she spends a lot of time, or maybe there's something that she didn't know about. So UC San Diego is doing this, but they're actually taking it a step further. So they've also employed a company called CitySense, who creates this personal pollution monitor. Now, I grant you, it's not small and beautiful yet, so that everybody would want to carry one, but it is effective, and it measures 3 different kinds of pollutants. It measures ozone, carbon monoxide, and nitrogen dioxide. And it's real-time, again, connects to your cell phone so that you could get real-time air quality measurements. So in this case, a person, roams around San Diego, and they can see in any one location what the air quality was in those places. In the little pop-up that's showing, there was no clear nitrogen dioxide or ozone, but there was a slightly increased level of carbon monoxide. So consider putting these things together. You might get a report something like this. So let me blow up the important parts. So here you have your air quality sensor measurements for all 3 different components that are being measured: the carbon monoxide in red, nitrogen dioxide in green, and ozone in purple. And these blue dots are where you used your inhaler. And so you might notice that sometimes your asthma seems to be triggered by carbon monoxide, a peak right before you used your inhaler. So you can start to figure out maybe what some of your sensitivities are, which ultimately could help you avoid certain places if you knew about that. But this is just one person. What if well, actually, I'll go back a little bit because I get excited. So Gloria, our patient, or Jillian, anyway, she can take her report and send it directly to her physician. So she's saying, here's my February 18th report. She'll get a confirmation email back from the clinician, and he'll be able to take a look and say, uh-oh, asthma's not well controlled anymore. We need to do something about this. So he may send a response back that says, okay, Gloria, you should increase the frequency of your inhaler to 2 puffs 4 times a day till your breathing's improving, and then I'm going to see you in clinic next week. So it's got the complete loop. She's able to quantify her own use of inhaler and pollution, send it in, have her physician be able to interpret the results, and send her treatment advice. So again, now imagine that you take this pollution monitor, for instance, and a number of people have them. And there's a website that puts together all of the results so that you can see real time in multiple places what the pollution level is, to get even better information than we get with our statewide monitoring systems. And maybe you not only do this for the pollution monitor, but maybe for everybody who's using one of the asthma inhalers with a sensor, and find out where people are using their puffers. So something like that is being done in Louisville, Kentucky. So Louisville, Kentucky is the 17th largest city in the United States, but they have one of the highest levels of hospital admissions for asthma exacerbation. So they have a beautiful skyline, but sometimes it looks like this. And so huge levels of ER and hospital use for asthma. But in 2012, they got from IBM a Smarter Cities Initiative grant. And so they wanted to take a really comprehensive look at what was going on to identify community-wide as many asthma triggers as they could. So not only using the data from the sensors on the inhalers, but using all sorts of transportation data, pollution data, anything that they had at their disposal was put into this. And I'm told that the results are impressive. I wished that I was able to report the papers, but I understand that they're in the publication process right now. But it does make us think, again, with this kind of an example, how can we take advantage of crowdsourced and population-based data to inform our personal health, to get it back to the health system so that they know what our triggers and our issues are? Well, I can tell you that this isn't just an American problem or challenge. It's going on elsewhere in the world, and I wanted to just show you the example of Tan Tock Seng Hospital in Singapore, who this particular hospital is the main acute care hospital in their region, and they have this issue of a quickly aging population and an increasing burden of chronic disease. Sound familiar? We all have these problems. And they have, in their hospital, realized that they were focused on episodic care. In other words, somebody gets appendicitis and they treat them and they go home and you're done. No more services needed, right? So you break an arm, you get your cast, and then you get it removed and you're done. That's an unsustainable model when you're thinking about chronic disease and functional capacity and all of the different kinds of social and home services that are needed to keep people out of the hospital. So they are implementing geomedicine, and their goal is to reduce the number of avoidable admissions in their hospital. Again, this is a universal issue that we deal with. So this is their tactics. So first, they're going to analyze medical data and demographic data, putting them together on their frequent admitters, so really focusing on that subpopulation to begin with. So they're looking at things like housing type, what diseases this population has, what is their proximity to other kinds of regional services within the network? In other words, why are they coming to the emergency room? And they're going to start with improving the transitions of care. So instead of just discharging out with no services, they're going to start to plan these services geographically that would be more convenient for the patient. And then they can start to move toward preventive models of care. So in order to do that, they've got to be able to understand and then anticipate, we hope, predictive modeling for the community healthcare needs so that they can start to proactively address them. They're going to be able to design targeted and hopefully effective community interventions. And they're also really focused on advancing and growing their network of partners. They're thinking about the general practitioners in these family community centers and all of the different kinds of social services all being in one network and everybody knowing where everybody is. And they have said that a location-aware system is critical for them being able to develop sustainability in their system. And so going from a very large health system and thinking about geomedicine, I wanted to bring it into a smaller health clinic. And a friend of mine, Dr. Rishi Manchanda, who wrote this book, The Upstream Doctors, and I have no financial interest in the book, although I can say it's a very good read. It reads like a novel rather than a textbook. But he's talking about how healthcare reform has led us to really focus on thinking upstream. And you heard a bit about that earlier today. But he begins the book with a story that I'll repeat, maybe not as eloquent as he does, but I really like the story. And it begins with three friends who come along the banks of this beautiful river. And they're standing there admiring the river and its grandeur. And they also note that at the edge of this river is this enormous waterfall. And as they're standing there admiring the river, they start to see a child floating down the river, trying to keep its head above water, just really struggling. And so they jump in and they grab the child and pull it to safety. Well, not seconds, not even a full minute before they get that child to safety, they see another one drifting down the river, and another, and another. So they are racing frantically to save these children and bring them to safety. And the current begins to get stronger, and they're saving most of the children, but not all of them. And they're wearing out. There's just 3 of them. So this problem is getting bigger and bigger, and they don't know what to do. And then one of them starts to swim away. And he's swimming upstream. And the friends, the other 2 at the riverbank, are screaming, "What are you doing? Where are you going? We need your help. We've got to save these children." And this man keeps swimming. And finally, he lifts his head and turns around and he says, I'm swimming upstream to find out who's throwing all these children in the river. He's going to the source of the problem, trying to figure out what's going on. And so that's what upstream thinking is all about. And geomedicine can help. Upstream thinking, as you may have gathered, is about social determinants of health, right? About social justice and equity, and particularly things like class, race, ethnicity, gender, immigration status, and sexual orientation. These are really important. And I have to read this for you because he says it better than I do, but Dr. Manchanda said, the nature versus nurture debate can no longer be viewed as a battle between equals. The impact of nurture in the form of the social and environmental settings that surround us is far more powerful than we've ever imagined. These are the forces that shape or distort our genes, our behaviors, and the landscape of opportunity in our communities. The current standard of care often ignores these forces. This lack of attention leads to missed opportunities to effectively alleviate suffering and can sometimes even contribute to more suffering. In the very first talk that you heard this morning, you saw the distribution of the determination of your health. And I have just another iteration of it here. And that is showing that, again, medical care and your genomic makeup are smaller parts of your health than the environmental factors that influence your behaviors that influence your health. So if you really want to have an impact in health outcomes, you've got to focus on the social determinants. And so he has. He has a small clinic in LA County, and he's put geomedicine to work in his clinic. Again, focusing on asthma and other what he calls housing-related illness, he used GIS to map 54,000 of the patients in his database. And what he saw surprised him a little bit. He saw clusters of asthma that he hadn't seen before. And so he got this idea and he cross-referenced those results with the local housing code enforcement records. He did note that those were hard to get, but he got them, and again, a plug for open data, and was able to put that together. So then it changed his practice in another way. So he started doing things that essentially are crowdsourcing, right? He developed an intake form asking patients some basic questions about housing, their school systems, and neighborhoods they live in. And then he linked their needs with the community resources that he had available. And those community resources were also crowdsourced because he asked people about what are your favorite parks in the area? What walking trails do you like? Where can you get fresh food at farmers markets in this neighborhood? He also was able to find lawyers who are willing to do pro bono work. And he put those lawyers to work with patients to help them with the housing code enforcement issues that was the cause of their asthma. Just giving them another inhaler wasn't going to cure their problem, but removing the insult really does give the potential to cure. And then he also sought dynamic teachers who were interested in health issues so that he could have community meetings and groups to get the message out and teach people how to connect with these resources. So I thought it was just a really great use of geomedicine in a small clinic that really made a difference for a lot of people. So I come to the considerations, a few thoughts as we embark upon this world of geomedicine. Epidemiologists are so important. I just can't stress that enough. I wished I'd had more epi training. I probably have enough training, but I really love epidemiologists. And they need to continue to do research on environmental factors that correlate with health risk. So things like, what is the dose and duration of exposure that causes illness? You know, when we think about when the electronic health record can look at our continuous lifetime of exposures, they need to be able to look at the interactions of multiple exposures and correlate that to our own individual susceptibility. You know, how am I different from somebody who might have an immune compromising disease? And how might the exposures impact the two of us differently? Epidemiologists, as all of us, should consider large geographies at local scales. And again, open data, making this stuff available. Consider making all of this available online so that they can be consumed by Individuals, there are a number of people, civic hackers they're called, who want to spend their leisure time helping government and helping health to do better. So making data available to them is priceless. And making data available to health systems that can also consume that information and make use of it within the system is critical. And of course, I've glossed over it in this presentation, but I have a strong recognition that patient privacy is always a critical issue that we have to deal with. And things like Safe Harbor, HIPAA, and in my state, the California Information Practices Act, are all things that we need to reconsider and update in the face of the technology changes that are coming about. There are also training implications when you think about all of this moving forward. Healthcare providers, particularly getting them early, like in medical school, need to be trained in the value of geomedicine and understanding that the context of spatial thinking is relevant in today's healthcare. And in terms of the social determinants of health, there's a little bit of progress. I'm told that the 2015 Medical College Admissions Test, or MCAT, will have a section on social and behavioral sciences. So that's a step in the right direction. Analysts of all type are going to be important. We need data scientists, computer scientists, epidemiologists, geographers, statisticians, and obviously healthcare providers, public health officials, policymakers. Many people are part of this. This is one of the best examples that I can think of team science, bringing together critical expertise in new areas. And over the last few years, there has been a lot of talk about personalized medicine. And by definition, personalized medicine is based on the awareness that your genetic variations can cause different people to respond in different ways to the same medication. This is obviously very important because when you take a medication, you want it to work. This is genome-based medicine. However, I would argue that your unique exposure history, where you've lived and worked throughout your lifetime, has just as much to offer in your healthcare and should be as well funded, and this is geomedicine. It is nature and nurture, there is no doubt in my mind. So I hope that I have told you about the converging of policies and technologies that are evolving and thus enabling us to create what really is a generational moment in healthcare. This is a special time. We're going to see things and change things in ways that I bet 10 years from now might not have even been imagined. The lines between public health and medical health data are definitely blurring with the decrease in silos around the way that data is handled and shared. I think that's a good thing. And geomedicine, I think, has the potential to create integrated, sustainable systems that use all of the data, as I mentioned in my title, and turn ink back into blood. Geographic data can make us healthier. And I am a true believer, and I think I have some time for questions.
Yourself, please. I'm Stanley Hall from RENSI, which is the Renaissance Computing Institute, and I work with some of the folks here in the room. Could you identify 2 or 3 of the key pain points in using data and geodata in medicine right now? What do you think are the places where we really need to focus our efforts in order to make more rapid progress?
Sure. Well, the first one to me is having geocoded data in the electronic health record. Even if it's just the current address, it would be a great start. I have geocoded data from our EMR, and it's a mess. We've talked earlier about the difficulty in cleaning data. So it is the #1 biggest headache barrier to getting things done. So that's the first thing. I think another pain point, as you say, would be vetting resources. So to me, one easy win in geomedicine is to line up your resources and have them mapped. And when you have a patient with a particular illness, you don't even have to involve the clinician necessarily on a post-visit summary. They can get resources for their obesity or diabetes that require quite a bit of counseling and nurturing to improve their condition, not just the medication. But somebody's got to vet the resources and keep them updated. You know, if your institution believes that Weight Watchers and Jenny Craig are both excellent programs that patients could go to, or that certain neighborhoods are safe one year, maybe they're not safe another, I think that is a challenge that is becoming easier, though, with consumable data. And so then the third part is for, I would say, health systems to learn how to consume and make use of publicly available data. Because there's a lot out there already, as I pointed out, and it could be used. So that's where I might start.
Flavio Rojas, U Clinical Research Institute. My question is the transition from chronic diseases to more infectious disease. We're all hearing now of Ebola. There are some institutional problems, perhaps, that organizations working too much in chronic diseases and clinical trials. How do you move from that kind of environment to one that is open to social environments, social conditions for diseases? And we are now facing Ebola. And what is the crucial part that you would recommend in a more institutional way?
It's a great question, and the first thing that comes to mind as you ask that question is the younger generation, which I don't want to discount my generation and those of you who are with me. I think of the younger generation as really being able to consume and interpret real-time data better than we've been trained to do. So thinking about that, how can we train ourselves to do it? I think a lot of it falls on public health. And as I said earlier, I think that we're starting to improve coordination between public and clinical health, but I think making those ties even stronger is really important, because public health is able to react to new infectious diseases very quickly. They have set up the infrastructure for that. So how can they use that efficiency and information to inform clinical health? I don't know the exact answers, but I think improving that partnership, maybe in technology ways as well as just the communication, is really important. And I'll just add a tidbit onto that, since it may seem obvious to everybody here that that would be a good thing. I have actually heard people in high places say, and I won't say the name, but said that they wouldn't spend $1 on public health until we solve all the problems of clinical health. It makes absolutely no sense to me. But my point is that not everybody feels this way, so it's worth saying that those relationships could help health systems react faster.
Hi, Shillery Ibrahim. I'm a health IT scientist at RTI. So I wanted to circle back to your comment regarding the quality of the geocoded addresses, the standardized addresses. Is that just a workflow training issue, or is that a limitation of the electronic health record?
It's both, and I'll give you an example. So the electronic health record is different from every system, right? I was just chatting with the folks at Cerner, so I'll give them kudos for creating an electronic health record that does start to standardize addresses, so you have a place for street address versus city, state, zip code. Some of them have that all in one field, and that makes things very difficult. So that's one component, is just having a way to input it that is standardized. That's the technology. That part's easy, really. So the training and education, I think, is where we also need to focus some time. So in my view, I'm thinking about that first moment when a patient comes into the system. I think that the geocoding should happen immediately. Patient gives their address, person puts it in, and the patient says, oh, I live at 180 Main Street, and the person then can say, oh, was that North Main Street or South Main Street? Because they've immediately tried to geocode it, and they get two options coming back. That's how you know that your data is quality and real, and you are validating it against the person. And again, I would say that there's big return on investment. It was mentioned earlier, you can actually get the bills to the patient and pay for the care. Yes.
I want to also comment, there's an HL7 standard for this that I think was validated 3 or 4 years ago, maybe 5. Now, having that standard validated and approved doesn't mean people will necessarily use it. So for anybody who's interested in that, go to HL7 and start to do your research on that. Discover there are some standards that are out there that anyone can follow in trying to improve the level of accuracy and detail of an ASTRI head.
Thank you, Bill. Yes.
John Delaney, I work on the credit indicators project for the city of Durham. And my question is, in addition to the open data you referenced showing locations of clinics, you can access that way, you also mentioned providing more robust local data for outcomes rather than survey data that relies on. Can you point to examples where summarized outcome data has been shared with public health or maybe even in political context?
Sure. Well, I can tell you where we're starting with California Public Health, and we just launched our open data portal in August of this year. And there's so much to be gained just from vital records data. So thinking about birth data, we can provide enough information so that people can calculate teen pregnancy rates, or I should say teen birth rates, because we don't know if they stopped the pregnancy. So, and then there's mortality data, right? You can understand where there are high levels of mortality. And I've analyzed mortality data in California and learned a lot of interesting things about places where, for example, youth mortality is higher than expected. And then I correlated that information with other publicly available data on foster care and poverty levels to find that youth who are vulnerable are also the same youth who are in places where they're dying at unexpectedly higher rates. So, those are outcomes, and you can use that information. So, so we're aggregating in California at the zip code level, which I think is unique for open data and vital records data in a state. Partly it's because California is big and we have 500,000 births per year. So we can do this at the zip code level. Again, the privacy part depends on the geography and scale. But definitely it's an option.
Kathy Cleavier, State of Louisiana Department of Health. I was recently at a state health policy conference, actually just last week, and there was research done by Elizabeth Bradley at Yale that looked at health outcomes in the developing countries and clearly showed that, as we all know, we spend a lot on healthcare, we get very little in terms of outcomes. We're the worst in the developing nations. So what they looked at instead was a ratio of what we spend on social to healthcare, and showed that the countries that spend a lot more on social have a better ratio of social to health, have much better outcomes. I'm just wondering if you've seen that data. I mean, it really supports, like the doctor you showed in your slide, that looked at all that social data and tried to gather that that community information for the patient, how that really helps in terms of outcomes. So I just wondered if you'd seen that, and I, like I said, I think it really supports everything that you said.
Yes, I hadn't seen that particular data, but I'm glad to hear about it. And I agree, a higher investment in the social services is really important. And coming from state government, and you may relate to this, people always talk about, our departments are called HHS, not just health, but health and human services. And we often forget the human services part, but that's where a lot of those social services are coming from. And when you think about things like open data, it becomes really challenging because these tend to be smaller departments with a lesser IT infrastructure, and also they have more qualitative data types rather than quantitative data types. So we really need to think about how we can leverage this information to start making those differences, because I believe in the data. I believe that it's very likely that when we focus on those upstream factors, we're going to improve health outcomes in the long run.
Any other questions?
So I'll ask mine. Okay, you make the comment that 10 years from now, we'll see a lot of this stuff happening. But that's part about making a 10-year projection, is nobody will remember you made it. So my question, not only for you, but hopefully it will come out of the discussion here, is what's going to make that change occur? Because I see these as almost isolated activities in some senses, not really moving into the flow of what's happening in terms of health reform and things of that nature, although it's critical to that. And, I can imagine when Katrina came through in New Orleans, if we'd had something in place like Louisville is trying to put in place, or some other places you were talking, it made a huge difference to understanding, assuming we're going to lose power, for example, and who is this going to impact? So the potential of this for life-saving is fantastic. What I don't see is a strategy for making something happen, a strategy for moving this in, because it's not in a beaten pathway of anybody says great with the things that you're talking about, but nobody is willing to make the commitment to make the step forward. So I'm interested in things that we can do maybe to begin to make this more real. So 10 years from now, I'll come back and say you're right.
I would love that. So a couple things. This is a beginning of like-minded individuals coming together to start to spread the word. We've got Cerner here, who is committed to standardizing addresses, and they're excited about the potential of geocoding them in the electronic health record. That, I think, is one of the first most important things. But another thing I think that is really important on at least two levels is language. As you mentioned, there are a lot of things going on sporadically, and they might not all be saying that it's called geomedicine, right? So I think having a common language about what we're doing is one important component. And then I'm going to take language to the informatics area and talk about interoperability and the language of informatics, having the same kinds of terminologies so that we all mean the same thing. I mean, there's been a lot of focus on that. As Bill mentioned, there's an HL7 messaging for geography. This is all really important. So making sure that we're all thinking on not our local standards level, but national standards, potentially even international standards as this all takes hold, that's going to make it bigger and more sustainable. So as people develop systems, stop thinking small, think big.
Where will the money come from? Who will pay for this?
Well, I understand you know some people in Washington. We need people to start funding this on a serious level, and not just the NIH, because I have not a bias, but a fear that people get creative with their research in order to get it through the NIH rather than practical. I really like support that may come from foundations and other folks that are looking for deliverables that need to be met. I would start spreading the word to foundations and people like Robert Wood Johnson, who clearly understand the benefit of geography and health, and other large foundations that can lend support.
Also, you are?
Oh, I am Alan Fremont. I lead a program I ran called QDART, based in Santa Monica. First, great talk. And a few thoughts. On the issue of how do you get this going, and let's
already changed the whole tone of their portfolio and now talk about a culture of health, which they did a 2-year study on social determinants of health and found that people didn't resonate with the term. Either it was seen as something that didn't make sense to communities, they didn't know what it meant, or in Washington, it was code for big government programs. So they have changed, for that reason and a lot of other reasons, they are now talking about a culture of health. So all of their funding looks at prevention and looks at community-based determination, has a lot of community-based advisory groups, not just other researchers, but people from the communities who are affected. And you were talking about zip code analysis. David Fleming in the city of Seattle has also been doing zip code analysis for hotspots where they found that the same places with high rates of asthma, same with cardiovascular, domestic violence, a lot of things cluster. So they've been able to use it very effectively, but of course California is always the national model.
I'd like to make a comment before I recognize Brian. So, this is the challenge of the leadership curve. What Ed is really going for here. There has to be some sort of action that like-minded people do together. For example, if you're familiar with Medicaid, we're going to have some talks about that from some experts that know this. You have a thing called the Medicaid Management Information System. For how many years, I can't really remember, 20 years at least, they've had the ability to funnel monies into states to actually grow and develop a very sophisticated management information system. Every state knows there's money there that they can build their capability and their staff capacity to work with this kind of data and so forth. Okay? Nothing exists in public health. Public health doesn't have a management information system that's continually promoting and building up critical infrastructure assets. So it should not be a mystery to anybody in the room why we don't have a national disease surveillance system. Right? You have to put the parts together and you have to make them work. So one of the things I think Ed is really driving at here, and I would like to encourage you, is to think about how we actually collectively move this to a different level on the agenda. I would tell you there's 10,000, I can name 10,000, I can't name. There's 10,000 case studies of the value of what it is we're talking about here today. How many more are required before a system moves? Or that someone said, we need to systematize what we're talking about here. But I think that's the real challenge, is how you take your blooming flowers and making them into a garden. And we're at that critical, almost tipping point, so to speak, I think, amongst ourselves and with, I would say, with the business, not necessarily business imperatives, but the social imperatives that are out there. We have Ebola out, and we're now talking about how do hospitals track their visitors, all their vendors that come into their facilities. You can begin to see that this thing is really connected. And what are we going to do to connect all this? Well, this is one of the solutions that's possible, but we have to think about it creatively and then strategically start to move it to a different kind of discussion platform to get some action. Because you can't expect health systems that are losing 20%. I mean, how anxious are they going to be to spend any kinds of money for hiring the kinds of people that are required to use this kind of information? I think that's a real challenge for everybody in this room to think about those kinds of things. Ryan.
Ryan Bogo, Louisiana Department of Health and Hospitals. I'd just like to add to that state's response to Dr. Hammond that we do have MSTAT now, and I think that was a result of a crisis. MSTAT is a system of, we track the census of all the nursing homes and hospitals during an event, typically a hurricane in Louisiana, so we can see not just where those facilities are, but how many patients they're housing, and also other information that's critical, like how much fuel they have left in their generators if they run out of power. And I think that came about because of events like Hurricane Katrina and Hurricane Rita, and just because it kind of opened up everyone's eyes to that we needed something like that in place. So it was like you're saying with Ebola and others in the room, it's sort of taking advantage of a crisis, using it to promote good. So I don't know how that happens next in making her statement true in 10 years, but perhaps it has something to do with what's
one more question right here. You were
The gentleman over there has his hand raised before
Where's that?
Yeah, I've got a blind spot over here, but that's
before you.
yeah, I'm short. Question goes. Go ahead.
Well, so I'll go on ahead. My name is Jefferson McMahon. I'm from Children's National Health System in DC. I have one quick comment and just a very short question that I think you'll be able to answer. First off, that was a great talk. As far as funding sources and how to get actionable, at my health system, the way our geographic information system program has been funded is through the Meaningful Use program, because when you think about it, they go hand in hand. And I'm really glad that you brought that up, because one of my hats that I wear, other than being the GIS champion, is to manage our Meaningful Use program. And so if you think about it, at a large tertiary health system, that's probably about a $5 million a year program. Some of that money can be diverted over to growing your GIS programs and growing what you can do with geographic technology. But my question is, in DC, we see patients from 4 or 5 different states. So as far as from a public health perspective and how we can work with those departments, do you have any ideas or sort of experiences of how we can work with our surrounding jurisdictions, because we have so many of them that we have to work?
Right, well, the first thing that comes to mind, and maybe is part of the easy answer, is that healthdata.gov is automatically taking from everybody's open data portals. It just, it takes a look every day to see who's got an open data portal and data that it can usurp, bring up and federate. So if the different states can be encouraged to open up their public health data, you don't have to necessarily share among states. You can just go straight to the federal website and it's all available. That would be the easier solution. But depending on your states, there are a number of organizations that support the health officers of different states, and so in those organizations there's the potential to create a movement or a coalition, a collaboration in which those states could get together to solve a common problem. So that might be a great place if you can inform your department directors and get them interested in those situations. And I also just want to take a moment to thank all of my colleagues here who helped to answer a really tough question. That's what I hoped for.
Just to follow up to your question about the surrounding jurisdictions, there's a proposal working its way to Capitol Hill from the Census Bureau, who has asked permission to establish a national address data bank. The Census Bureau actually has more addresses that are deliverable than the post office. And if you realize that, if you live in one of these neighborhoods where you have a box down at the end of the street, that's where the post office actually thinks you live. Right? The Census Bureau actually goes to where you actually live, your head down. And even if you're homeless, they know where that is. You have about 40 million additional addresses that the post office has. So they made a recommendation to Congress to give permission to allow them now, with the use of the cloud, to be able to stand up a service that would be available to any healthcare provider or any administrative body to actually have an address standardization process that is more useful and more helpful. Of course, that might take 10 years, but I would say it's a start where we're clearly seeing some much broader thinking about how we clean up the addresses that are feeding our administrative systems. Go ahead. We're going to let I'll ask one more question.
I guess I have the dinner talk tonight, so I'll be brief. But this is sort of throw a torch on the inland here. I feel like I'm in sort of a strange place here because I'm working with people within health systems every day who use this technology, but they're not using it for the purposes that you said. They're using it to optimize their pyramids, to optimize the profitability of their health systems. And I do want to correct one thing you said. The average health system in the U.S. is not losing 20%. It's not the most profitable business in the world, but if you look at the big integrated health systems that are developing, they're actually doing pretty well right now. They're all predicting doom and gloom, but there's money in these systems. The technology is being applied for reasons other than public health. It's being applied to run a business. Just like most businesses, major businesses in the U.S. are already doing this on a routine basis, whether you're Walmart or Whole Foods or whatever, using geospatial technology to California, we're finding in North Carolina, the biggest issue is health systems regard the state as an asset. And they actually, while they may exchange transactional